Now, epidemiological spectrum of retinal vasculitis. There is a considerable geographic variation in ophthalmologists' perspectives on what retinal vasculitis represents, alone or with concurrent uveitis. The default association in the Indian subcontinent is with tuberculosis or Eales disease. Elsewhere in Asia, including China and Japan, and the Mediterranean region, retinal vasculitis means Behçet's disease. So when there is retinal vasculitis, if you see periphlebitis, it is in India. It is like location based, geography based, where it's occurring vasculitis. If it is in India, then it is mostly tuberculosis or Eales disease. Now, if it is China and Japan, just think about Behçet's disease. And in United States, Japan, Northern Europe, think about sarcoidosis. That is the most common association. In South America, Europe, Australia, Africa, toxoplasmosis. So the main things is the first intraocular inflammation to rule out. So depending upon the locations, India, tuberculosis, Eales disease, about vasculitis. Then in China and Japan, it's Behçet's disease. Then sarcoidosis in United States, Japan, Northern Europe. In South America, Europe, Australia, Africa, toxoplasmosis. So America, Africa, Europe, these developed countries, you think about sarcoidosis, autoimmune diseases, sarcoidosis, and toxoplasmosis, infectious disease. So the infective etiologies are typically more common in developing countries, whereas non-infectious vasculitis is the norm in the developed world. The ethnic or cultural subtext in etiologic diagnosis must also be kept in mind. Tuberculosis or Eales in Asian Indians, sarcoidosis in Scandinavians and African Americans, Behçet's disease in East Asians, and toxoplasmosis in Europeans, native Australians, and South Americans. The migration of ethnic groups across the globe has complicated the epidemiologic profile of retinal vasculitis to some extent, but broad causative associations remain relevant. Finally, irrespective of geographic and ethnic riders, retinal vasculitis as the predominant feature of posterior uveitis has only a few key systemic associations: tuberculosis, sarcoidosis, and Behçet's disease. So we'll see some pictures. Figure 84.4. Mid-phase fluorescent angiogram of a patient with Eales disease showing scattered peripheral areas of capillary microaneurysms, telangiectasia, collateral formation, and retinal non-perfusion, most prominent at 3 and 9 meridians. The posterior pole is largely unaffected. The inflammatory sheathing of inferior temporal retinal vein from the first branching downward arrow is not apparent due to resolution of active vasculitis. Figure 84.5. The patient underwent peripheral scattered photocoagulation for post-inflammatory neovascularization in Eales disease. The picture shows simultaneous recurrence of neovascularization arrow and vascular inflammation arrowheads. The inflammation was treated before neovascularization. Note the lack of involvement of the posterior pole. Now figure 84.6. Post-vitrectomy view of an eye operated for persistent vitreous hemorrhage and vitreoretinal traction due to Eales disease. A large tractional band with anterior attachment persists at 3 o'clock meridian. Scatter photocoagulation marks extend posteriorly all around due to widespread vascular occlusions. Note the disc pallor due to extensive retinal ischemia and to heavy panretinal photocoagulation. Now the management. Management: patients with resolved vasculitis and clear media should be followed up at 6 to 12 months interval. Follow up 6 to 12 months if it is resolved vasculitis and clear media. When the vision is good and the macula is healthy. Minimally active peripheral vasculitis may also be observed, though with close follow-up. Fundus examination of the unaffected fellow eye is mandatory because it is eventually involved in 90% of the cases. Once systemic and ocular infections have been ruled out by history, examination, and investigations, corticosteroids are the mainstay of treatment for active vasculitis. Vasculitis inflammation, so corticosteroids, mainstay of the treatment. In active, it should be active vasculitis. In unilateral presentation, periocular or intravitreal depot corticosteroids such as intravitreal steroids. Now, corticosteroids intravitreal. Depot corticosteroids such as triamcinolone acetonide or dexamethasone implant. Dexamethasone implant is Ozurdex or triamcinolone acetonide. May be used to avoid the side effects of long-term systemic corticosteroids. A randomized trial showed significantly better efficacy of intravitreal steroids, triamcinolone and Ozurdex, over posterior subtenon injections for uveitic macular edema with modestly higher but manageable intraocular pressure elevation. So what they are saying is intravitreal steroids, Ozurdex, triamcinolone acetonide, were found to be better over the subtenon injections for uveitic macular edema in case of the Eales disease. When the vasculitis is bilateral or severe, or when there is inadequate response to periocular injection, systemic corticosteroids, typically oral prednisolone, 1 mg per kilogram body weight per day, should be considered when systemic is given when it is bilateral and severe, and there is inadequate response to the periocular injections. Then you give it systemically, 1 mg per kilogram body weight per day. And corticosteroids by oral or local routes are almost always enough to control the inflammation in Eales disease. Immunosuppressive agents are rarely required in the presence of a positive tuberculin test. Some investigators recommend antitubercular therapy. However, its role in the treatment of Eales disease is limited, 5% in the largest study of Eales disease, unproven and controversial due to drug toxicity concerns, and usage should be decided by an internist. Even in a non-endemic settings, mild uveitis with a positive IGRA does not automatically require AGT. Once the proliferative stage is reached, peripheral scattered photocoagulation in the ischemic areas bordering the neovascularization is the treatment of choice. Treatment can be extended posteriorly following the retinal non-perfusion and presence of posterior or disc neovascularization. Scatter photocoagulation is not recommended in the absence of neovascularization for peripheral retinal non-perfusion, which is nearly universal in Eales disease. If there is peripheral non-perfusion, then don't go for photocoagulation. Only when there is neovascularization, go for scatter photocoagulation. Photocoagulation is also contraindicated in the presence of active vasculitis, which is likely to flare up and release more angiogenic factors aggravating the neovascularizations. Pre-treatment with corticosteroids sometimes mitigates the need for subsequent photocoagulation. Mitigates means decreases the need for subsequent photocoagulation as well. Timely and appropriate treatment with corticosteroids and laser photocoagulation substantially improves long-term visual outcomes. Persistent vitreous hemorrhage is the most frequent indication for vitrectomy. Early intervention within about 3 months begets better visual outcomes. Early intervention within about 3 months begets better visual outcomes. Persistent vitreous hemorrhage. So epimacular membranes or extramacular retinal detachment warrant consideration of early vitrectomy when there is retinal detachment and epimacular membrane is there. And macular detachment mandate the vitrectomy. Results of vitrectomy in Eales disease have been reported for about 3 decades. However, there is marked discrepancy in the reported outcomes due to variability in case selection, mainly PVD status and retinal detachment. With modern surgical instrumentation, good surgical outcomes are possible in spite of incomplete or anomalous PVD and tractional sequelae. Surgical instrumentation and preference have now irrevocably shifted toward small gauge 23-27 gauge sutureless vitrectomy for the entire vitreoretinal surface surgical spectrum, including Eales disease. Excellent outcomes and faster recuperation are now common. Recuperation means recovery. However, encircling belt buckle may improve the surgical outcomes in the presence of peripheral tractional membranes, especially in younger phakic patients with clear lenses. Clear lens, younger phakic patients go for encircling belt buckle in peripheral tractional membranes. Anti-VEGF drugs like bevacizumab have been used as adjuvant to scatter photocoagulation and vitrectomy. Although bevacizumab probably has merit in treating neovascularization refractory to scatter photocoagulation and in serving as an adjuvant to vitrectomy, bevacizumab cannot substitute vitrectomy for vitreous hemorrhage in Eales disease, and it can precipitate tractional complications. Bevacizumab. The patient should always be cautioned about the need for vitrectomy prior to anti-VEGF injection. The patient should always be cautioned about the need for vitrectomy prior to anti-VEGF injection. So, in short, the management of vasculitis, if it is vasculitis, resolved vasculitis, clear media, 6 to 12 month follow-up, and if it is active peripheral minimal vasculitis, observation, close follow-up, 3-monthly follow-up, and fellow eye examination is important because 95% of cases it is involved. Then obviously, first steroids, intravitreal steroids or systemic intravitreal when it is unilateral involvement, mild involvement, and peribulbar injections. And in case of the macular edema, also dexamethasone, also dexamethasone. These intravitreal steroids are proven to be better than this intravulvar injections. So subtenon injections. And then if it is bilateral, severe and inadequate response to the periocular injections, go for steroids, prednisolone 1 mg per kilogram per day. After that, tuberculosis treatment. Tuberculin test was obviously simultaneously treat the tuberculosis if it is required, but most of the times it is not required. It is just association if the tests are positive, like proper if the patient has symptoms. Once the proliferative stage is reached, then if it is neovascularization, then only go for scatter photocoagulation. Then there is, if it is vitreous hemorrhage with no RD, no PVD, macula is involved, it is not very severe and not long standing, then just let it resolve. Then if there is epimacular membrane, long standing VH, macular detachment, PVD, the extramacular retinal detachment is there, then go for early vitrectomy. Yeah, so steroids, intravitreal steroids, systemic steroids, then scatophotocoagulation, and vitrectomy. And if it is young patient, and if it is anti-VEGF injections, but anti-VEGF injections in case of NV, but if it is a RD and long-standing, then it is of no use. No use means it is first vitrectomy and then anti-VEGF. And if the patient is having active vasculitis, first treat it with steroids, and then if required, and if there is NV, then go for laser treatment, scatophotocoagulation, otherwise it aggravates the condition. So steroids, systemic oral steroids, scatophotocoagulation, then if required tuberculosis treatment, anti-tuberculosis treatment, then anti-VEGF injections. But if vitrectomy is to be done, first vitrectomy and then anti-VEGF injections. And if scatophotocoagulation is required in active vasculitis, then it should not be done in active vasculitis. First, let it its intensity should be mitigated with steroidal treatment. Then, now what is the summary? Summary of Eales disease. Though numerous ocular and systemic diseases cause retinal vasculitis, isolated retinal vasculitis as seen in Eales disease has few systemic associations. A detailed history, clinical examination and specific investigations as indicated by the positive findings are cost effective and sufficient. Once the diagnosis of Eales disease is established, most cases are usually observed. Corticosteroids are required when vasculitis is significant. Peripheral scattered photocoagulation is effective in the proliferative disease but should be deferred in the presence of active inflammation. So active inflammation, active vasculitis, don't go for scatophotocoagulation. Let its intensity be less, let it be quite calm with steroids, and then go for scatophotocoagulation. Recurrent vitreous hemorrhage and tractional complications require consideration of early vitrectomy with judicious use of medical and surgical treatment options. Visual prognosis is good in most cases. Although corticosteroids and scatophotocoagulation remain the standard of care, pharmacotherapy using anti-angiogenic molecules, antioxidants, and antibodies against specific inflammatory cytokines may play a larger role in the future treatment of this enigmatic disease. Enigmatic means mysterious. Enigma means mystery. So that was all about the Eales disease, and first go through the short videos that I'm going to share the link of in the description box, and then go through this video, and again you can go through the short videos for the rapid revision. So you have to give 1 hour to 1 hour 15 minutes for this chapter for the better understanding of this chapter, which is one of the differential diagnosis of the recurrent vitreous hemorrhage in young individuals. Thank you so much for listening to me patiently. Bye. Good night.